Hello, everyone, and welcome to MSK Unknown Case number 80. Here we have a really awesome case. I'm excited because this is a bread and butter case. We have a frontal view of the hand. And the high-yield question I have is, what laboratory abnormality may this patient have? Elevated alk phos levels, elevated rheumatoid factor titers, hyperuricemia, or hypercalcemia? What laboratory abnormality may this patient have? If we come back to this frontal view of the hand, notice first of all that there's these soft tissue calcifications, right? There's this like soft tissue calcification here at the wrist. There's also other radiodense soft tissue swelling here along the third DIP joint, the third PIP joint, even here, the second and third MCP joint. So these are all tophi. These are all calcified tophi in the hand. And if we take a look at many of the joints, they have these erosions, right? Like along the periphery, these are known as juxtaarticular erosions. Very well defined right outside the joint. You can see them here at the third DIP joints as well, the fourth DIP joints, right? They're at many joints, juxtaarticular erosions, very well defined in the presence of soft tissue calcified tophi. This is a case of gout, okay? A case of gout. And of course, the answer here is going to be hyperuricemia, which is what gout does, right? Elevated alk phos would be in something called Paget's disease. Elevated RF would be in rheumatoid arthritis. And of course, hypercalcemia occurs in primary hyperparathyroidism, where you get osseous resorption of bone. So this is a great case of gout. Typically, you get monosodium urate crystal deposition around joints and soft tissues. Laboratory-wise, you can have elevated uric acid levels. This is most common in white elderly males, okay? And this most commonly happens at the great toe, right? The first MTP joint, the first metatarsal phalangeal joint, when there's acute pain and redness. It's known as podagra, right? But the interesting thing and peculiar thing about gout that I think many people don't understand is that it can actually occur in anywhere in the body. It's one of the only chronic arthritides that can result in findings in nearly every joint of the body. But of course, the first MTP joint at the toe is the most common place to get gout. The findings that you see are soft tissue swelling. You get calcified tophi, like in the index case, juxtaarticular erosions, right? Erosions that are not quite in the joint, but right outside the joint. They're typically very well defined, right? Erosions in rheumatoid arthritis tend to not be very well defined, but these are really well defined erosions. They often have sclerotic margins, overhanging edges. These are classic manifestations of gout. And dual energy CT is becoming much more useful in the diagnosis of gout. It uses, color-coded pixels to identify the monosodium urate crystals. And I want to just give a toned-down view of this because I think it's really important to identify, first of all, we have these, radiodense foci that represent the tophi that we see in gout. And then we have these erosions, right? These are juxtaarticular erosions, really well-defined, kind of right outside the joint, right? This is the periphery of the joint. They're like right outside the joint, right? That's why they're called juxtaarticular erosions, really well-defined, have sclerotic margins. These ones don't necessarily have overhanging edges, but you can have overhanging edges. But notice also that the joint space otherwise is preserved, right? You don't really get a lot of joint space loss in gout. You typically have normal mineralization until end-stage disease. Really nice example of what gout would look like. And I also want to just show a classic case of gout in the elbow, because when you get soft tissue swelling posterior to the olecranon, that's just olecranon bursitis. And people forget that olecranon bursitis is a classic manifestation of gout, right? Particularly if it's bilateral. If it's bilateral, gout should literally be the first thing that you think about when you have bilateral olecranon bursitis. If it's unilateral, then of course there's a differential. It could be rheumatoid arthritis, it could be from infection, but you definitely want to look at this, especially given the fact that there's all this soft tissue tophi here and olecranon bursitis. Gout should be one of the first things you think about in this case. Thank you so much for your attention. Hope that was helpful. Please subscribe to our MediD page YouTube channel, and we'll see you next week for another amazing high-yield MSK unknown case.